Hello, everyone, and welcome to this week's COVID-19 office hours. My name is Natalie Matthews, and I'm just going to spend a brief moment or two going over some logistics for today before I turn things over to the great team of presenters that we have. So a bit of a reminder by way of housekeeping, we are in fact recording the webinar right now, and we will post a copy of that recording along with the slide deck and the content from the chat on the HUD Exchange. Just give us 2 to 3 business days, and it will be up there on the link that appears on your screen, and then I'm going to go ahead and put in the chat for you all right now. Additionally, we have found that in general, phone audio tends to be clearer for participants than computer audio. So if you have any difficulty hearing the audio today, go ahead and switch over from, if you're on computer audio, switch over to the phone, and that should help ensure that you can hear everything clearly. And I'm just going to put that information in the chat for you as well. To communicate with us throughout the webinar today, we ask that you go ahead and use the chat functionality in WebEx. So if you look on your screen right now, you should see the menu of icons that appears on the slide right now. All the way over towards the right, you'll see something labeled the chat bubble, and if you click on that, that will open up the chat functionality for you. Please send in questions, comments, feedback, thoughts that you have in that chat box. And when you are sending those messages, please make sure that you are sending them to everyone. And that will ensure that both the panelists and the presenters today are able to see the content as well as all the attendees. And with that, I'm going to turn things over to Norm Suchar from HUD's Office of Special Needs Assistance Program.
Thank you so much, Natalie, and I'm going to just introduce our speakers real quick, and then we will jump right into our content for today. So you can see who we have from the Department of Housing and Urban Development, from the SNAP's office on the line, myself, Norm Suchar, Lisa Kaufman is available, Marlisa Grogan, Abby Miller, Ebony Rankin, and William Snow, all available to help answer questions today. We have a couple people from our field offices, Taylor Keeley and Aaron Weaver, David Canavan and John Gilbar, 2 of our technical assistance providers. John will be presenting on some new technical assistance materials. So moving on to the next slide, we'll have our CDC update from Lindsay Branco. And we have a guest presenter today, Sandy Festa from Atlantic Care Health Services, and also Barbara DePietro from the National Healthcare for the Homeless Council. In addition to that, we have Dina Hoosier and Jill Weber available from Veterans Affairs to help answer questions. So with that, we're going to jump right into our CDC update. So I'm going to turn things over to you, Lindsay.
Thanks, Norm. This is Lindsay Branco from CDC's COVID-19 Response Homelessness Unit. Next slide, please. We are, for our situational update on COVID-19 case counts, we are at 7.5 million cases reported in the United States currently as of yesterday. That's approximately 315,000 new cases since last week. The graph shows the epi curve with the number of cases per day with the 7-day moving average is the red line. And as you can see, unfortunately, we're on an upward trend of cases. I did want to mention today also just to encourage all of you, if you're not already doing so, to be aware of the trends in your state and community as they really do vary widely from the U.S. trend. And just these are available either through your state health department or you can access them via the CDC COVID data tracker, and I'll put that in the chat box for anyone that is interested. And that is all we have today. Thanks, Norm.
Great. Thank you so much, Lindsay. And so just a quick question. We're obviously heading sort of from summer through fall into winter. Anything we should expect as far as changes in the direction of that curve? What are we looking at as far as cases going forward? Is winter going to be a time we should be sort of heightening our attention, or will we get a break?
Yeah, I think definitely in terms of folks being inside, so I think just critical to keep following the CDC guidelines in terms of social distancing. And we are hoping to have some additional guidance about ventilation for the homeless shelter specifically, hopefully available for you soon.
Great, thank you so much. So we're going to move on to our technical assistance spotlight today. So I'm going to turn things over to John Gilvar, and he's going to talk about some of our new resources. John?
Great, thanks, Norm. So I'm going to talk about two new documents, guidance documents that have just come out. The first is the framework for enhancing safety in your homeless response system, and the second is what to expect from remote case management. Next slide, please. Next slide. So the framework document, this guidance was created to help communities to weave together strategies for protecting people in high-risk settings, mostly congregate settings, but also living outside in encampments, et cetera. And weave that together with developing or strengthening the path to speeding the transition of those folks into safe and sustainable housing. And so there are two overarching goals for communities that are using this framework. The first is to incorporate public health guidance and best practices for reducing disease transmission, into the policies and procedures that they have for congregate shelters, other congregate settings, encampments, et cetera. Now, the second is to recognize that permanent housing provides a safer environment than congregate settings, given the inherent challenges around crowding and proximity in congregate settings. Next slide, please. So there are 7 sort of strategic elements for an effective framework. The first one is talked about a lot on office hours and will be talked about more throughout this presentation, today's office hours. Developing and sustaining close coordination between public health, or between the continuum of care and the homeless response system generally, and public health and healthcare providers. Preventing virus spread within the sheltered population and in other congregate settings. Maintaining essential services, including outreach, food, water, survival services for unsheltered people. Deploying targeted coronavirus testing, which I'll talk more about in a bit. Ensuring the availability and proper use of PPE. Accelerating rehousing processes, especially for people with high COVID-19 risk. And then keeping people out of the shelter system and off the streets altogether through prevention and diversion. Next slide, please. So the collaboration that I talked about before between the homeless response system and public health and HCH, Healthcare for the Homeless, and other community health providers continues to be critical as communities head into colder, wetter weather, as Norm just asked about. So there are a ton of linked resources in this guidance that will help planners to frame the critical safety questions that they need to be asking their public health and other partners. So some of those that are coming up around the country and that will be addressed in additional future guidance documents that are on their way to being published now. But just to outline them here, how will we meet increased demand for services without also increasing the risk of spread? So some of these links in this guidance that I'm presenting on today link to various best practices or promising practices for accelerating rehousing, establishing housing surges or rehousing surges safely within the midst of a pandemic. They also talk about infection control and reducing the spread of disease in congregate and non-congregate settings, including non-congregate shelters that have been set up. The second area of common questions that are coming up has to do with can temporary cold weather sites incorporate infection control and other public health best practices sort of on the fly as they open up. And the document links to training materials that are based on CDC guidelines. So there are lots of ways to kind of plug and play, if you will, training for people that will be operating new temporary shelters during cold weather. The next is around COVID testing strategies, how they need to flex and adapt to winter conditions. So there are links to lots of different documents around different testing strategies, including those put out by the National Healthcare for the Homeless Council. There are also links to how to work with unsheltered folks, which becomes more and more important as the weather gets colder. And then finally, how will shelter outreach and other providers rule out COVID-19 when a person they're serving has symptoms that could indicate flu or COVID-19. And for people who were on a previous office hours, there was a presentation about the overlap in symptoms between flu and COVID-19. So really the links here point to just how essential it is to coordinate with public health, healthcare for the homeless, other community health providers around symptom screening, isolation and quarantine, testing, flu vaccinations, et cetera. So there's lots of great links there as well. All right, next slide, please. So the next, the other document that I wanted to cover today actually is very relevant to the presentation that's coming up on telehealth. So this document is what to expect from remote case management. And this is a document that the audience is really the clients who are adjusting to remote or virtual case management, or also adjusting to getting their healthcare services via telehealth. So the guidance assures that there's continued client engagement and case manager responsiveness by helping clients navigate common tech questions around the different platforms, Zoom versus other different meeting platforms, or there's issues around Wi-Fi connections and so forth. They also talk about participating in virtual case management from spaces where privacy may be an issue, and also managing communications about meeting times, or just making sure that urgent needs are met and responded to in between scheduled sessions. So with that, I will hand it back over to Norm.
Great, thank you so much, John. So next, I'm very pleased to introduce Sandy Festa from Atlanticare. And so she's going to give us a nice presentation on telehealth. So Sandy, I'm turning things over to you. You may be on mute there, on your computer probably. Should see a button in WebEx that you...
Norm, can you hear me?
Yep, you sound great. Thank you.
Good. So thank you, everyone, for allowing me to present. I'm coming to you from Atlantic City, New Jersey, and I'm going to be talking about telehealth for the homeless. Next slide. Just to give you a brief overview of Atlanticare Health Services, we were a federally qualified health center funded in 2003. We were one of the healthcare for the homeless that was strategically located in a shelter that housed more than 3,000 people per year. We started out with a primary care drug and treatment license. And then in August 2016, we received expanded scope to treat the general medically underserved. Next slide. So this is a picture of our healthplex in Atlantic City. Just to give you a sense, lots of people think the glamour of Atlantic City. It's only 48 blocks, and the street at the end turns into the ocean, so people don't usually drive through, and a lot of people get stuck in Atlantic City. and are homeless. Next slide. And this is the shelter that we originally opened up our primary care practice in. It's a religious-based organization that's been there for more than 50 years. Next slide. So I wanted to, share a picture of what one of our exam rooms looks like. And I don't really think you need a picture of my exam room to know what an exam room looks like. But the reason why I shared it was because the pandemic has shaken all of our lives. And telehealth seems to be a great idea, but a lot of people that don't have a phone don't have access to telehealth like traditional people that may have a safe roof over their head. So in that building that I showed you earlier, where we have our federally qualified health center flagship site, we started to use our exam rooms as a place for people to walk in and do telehealth from our exam rooms. Much like many of you, when the pandemic hit, we had to send a lot of our staff members home, or maybe all of you sent everybody home. And so we had a lot of providers working from home, which worked well for that, except we didn't have a way for our homeless patients to connect to the safe providers at home. I think our experience has been much like lots of other health centers in that we were not an early adopter to telehealth. I've told the story several times that on March 26th, we did no telehealth at all. That's the big zero. March 27th, we did 3. And by March 30th, that following Monday, we did 200. I will tell you that our experience is like some centers in that our telehealth has truly helped us increase service access and decrease no-show rates, as well as providers like to work at home, at least for some services. We can't kid ourselves that not everything can be done over the phone. But I wanted to share this picture to let you know that we have to be creative when we're stuck in these situations, and I know you don't need me to tell you that. Next slide. So our lessons learned, we try to keep it simple. We really recommend do what it takes to get the care our patients need. The second thing that we'd like to share is have your team try innovation when you don't need it. Because when you do need it, that muscle needs to be exercised. The third thing we'd like to share is walk in the shoes of the patient. And I know we all kind of say this and do this, or we try and we have to be reminded. Telehealth was hard for us because a lot of people ran out of minutes or didn't have a phone or were a little bit paranoid about the phone. So, I mean, we could go on to the depth and breadth of the complications. And as many people espouse how great telehealth can be, there's also a downside, which brings me to the last point that I want to make. Telehealth isn't for everyone. And so what we've made a commitment to is possibly hold on to 30% of telehealth as we march forward through the end of this pandemic and beyond. Some people, it'll be great because they won't have to use food money to put gas in their car to get to the clinic. And then other people really want to be around people. And if we can pull ourselves together, mask, social distance, and other things, we still have to be a place for people to come to. Next slide. I thank you for your time, and I'll answer any questions when the office hours are open.
Great. Thank you so much, Sandy. And I'd encourage if anybody has any questions, go ahead and put them in the chat box. We'll have a lot of time for Q&A later. But with that, I'm going to turn things over to Barbara DePietro from the National Healthcare for the Homeless Council, and she's going to talk a little more about the partnerships between emergency shelters and healthcare for the homeless programs. So Barbara, over to you.
Thanks, Norm. Really appreciate this discussion. I think telehealth, as Sandy had talked about and just illustrated one example of healthcare providers and shelters working together, creating space. Telehealth just offers so many more opportunities now for access to care, particularly for the people that we're all collectively serving. Next slide, please. Just want to talk real quick about some of the policy agenda that's going to be really important to maintaining the kind of new telehealth work that we've been doing. During the public health emergency, we've been able to do a lot more flexibilities in how we're doing telehealth. And so this has made some of these new partnerships a lot easier to establish. And so I don't want to get into the healthcare policy weeds too much. And I know Medicaid is not typically where a lot of the advocacy in the HUD and COC provider community is, but at the same time, just appreciating that all the flexibilities we have to do the phone only, to be in different places, flexible places, and have that be a recognized therapeutic visit. And some of the things that we've been able to waive in terms of administrative paperwork, like consents to care and all of that, that's all temporary. And so if we want to be able to make these long-term collaborations and really ensure that we're making permanent the kind of access to care that we're seeing, state Medicaid plans are going to have to allow these types of things to be made permanent. Otherwise, all of these abilities will expire when the public health emergency expires. So I just want to make you aware that there is a Medicaid component to this, and to the extent that some folks might be involved with their Medicaid policies or their state plans, please be aware that telehealth is a really important piece here. And then a second piece, and Sandy mentioned this, is that a lot of people have a phone now, but they may not have enough minutes. They don't have a data plan that's sufficient to get through a care visit and do everything else that you need to do in your life. So just thinking through how we can be creative in facilitating phone access, whether it's actually purchasing phones for clients, and there is an ask a question where your COC funds, this is an eligible expense, given certain considerations, that you can purchase phones and data plans for clients. So again, a lot of this could be a really good use of the CARES money or other funding that you have available, and a really great collaboration. Next slide, please. And then we just think about just some of the nuts and bolts and the operational pieces that we might think in terms of an action plan. Specifically, that might be HUD provider focused, particularly for shelters. The partnerships that really thinking through how do we use the space that's available to us. These rooms do not have to be fancy or outfitted with any high technology. An iPad and someone who might be able to be trained to help the client access some things really can be sufficient to meet the need. So just thinking through how can you develop or expand that capacity. I had mentioned the phone and the data access. And then doing some training and support, and this also can be a collaboration with your healthcare partners, is thinking through how can you do some staff training so that people are more familiar with the iPad or the platform for the telehealth visit itself. It may be that there's some money for some capital changes if you want to outfit a room in some way or create a room. And then also helping clients. Maybe there's some trainings or even just some information or a tip sheet that can be developed to help clients be more comfortable with the technology. What we are hearing from providers is that while it works really great for a lot of patients, some folks just are not really comfortable with the technology. So if we can just do more technology literacy, frankly, I could use that as myself when I'm being taught something new. So I think that's an opportunity. And then again, coming back to the state Medicaid plans and making sure that healthcare providers that you're working with are able to continue doing this after the public health emergency expires. So I just wanted a chance to kind of tack on to what Sandy had described as the partnership she has in Atlantic City, but there's a lot of these partnerships that we'd love to highlight. They look lots of different ways, and so maybe there's just a way that you could be thinking through how you either start something like this or how you might be able to expand on it. And we're really looking for these models of care. So even if you've got something really great going on in telehealth, put it in the chat box. I'd love to follow up with you and find out more. So with that, Norm, I will hand it back over to you.
Thank you so much, Barbara, and thank you again, Sandy. So we have a few questions that we'll go ahead and start going into. Just want to remind everyone, if you have any questions, feel free to type them in the chat box. So I want to start with one about ideas about how to pay for phones, minutes, tablets, those kinds of things. Barbara, you talked about some of the CARES Act funds that can be used for those. Like in your sort of work with health centers and such who are doing this, how do you find that most of them are paying for those kinds of things?
This has been different arrangements. So some folks talk about how many of us already have contracts with T-Mobile or AT&T or some of the big communications because we've got phones for our staff and we've already got telecommunications in our clinics. So some folks have had a collaboration where T-Mobile or one of those folks said, hey, we'll donate 100 phones to this effort, or we'll contract with you very cheaply for a bunch of data plans to go with those phones. So that's been one place with your existing telecommunications provider. Another example is the philanthropic community who's been really interested in how they can be complementing what the public funds are doing. So looking to your private funders or your philanthropy in your community. And then also COC funds. And I know that I had the link real quick, and it may have already been provided, but I can put that in the chat too, to more information about how you can use your COC funds for these phones. So there's been several different ways that people have been doing that.
Well, we just happen to have some COC funding experts on the line who can talk a little more about how you can use COC funds. As a matter of fact. So, Ebony, can you talk about we'll start with the COC program, but can you talk about what are the sort of rules and requirements around and what you're allowed to do as far as providing phones for things like remote case management and things like that?
Supportive services to provide phones, minutes, or tablets for to folks who are providing that remote case management. So we've said you're allowed to use your supportive services to do that on the COC side.
Sorry, my audio dropped off a little bit there. Marlisa, can you talk about this in the context of the ESG program?
The FAQ in the chat. But yes, you can use ESG funds related to case management, so either under essential services under the shelter operations budget line item, or housing stability case management under rapid rehousing or homelessness prevention to pay for cell phones or related minutes to be able to facilitate. It's sort of like an overhead cost for to be able to provide case management.
And the question came up about having to return the phones. And so, like, you know, if you purchase a phone for remote case management, and once the pandemic is over, or how do you handle the actual phone, right? Do they have to return it when it's done, or are there, the person asking the question in the chat talked about Like, can you use disposable phones? Can you talk about that as well, Marlisa?
Yes. So they're considered equipment for purposes of case management, so they do remain the property of the recipient or subrecipient. So they would need to be returned. They're not considered the property of the program participant, and they're not being purchased for the participant. They're on loan. So definitely recommend everyone take a close look at the FAQ if they're considering this expense.
Great, thank you very much. We have a question, Lindsay. I wanted to sort of throw this over to you. I know you responded in the chat, but I think it's something that everyone's interested in. So you talked about air circulation and filtration. Can you talk about, specifically in a shelter context, like what should people be looking at as far as improving their HVAC systems or their air filtration? Like, I don't know, people who operate shelters aren't necessarily like HVAC experts. Like, what should they be looking at there? And where can they go to find more?
Yeah, and I did, until the guidance that we are adding is available, I did put in the guidance that's for the employer information for office buildings, as it's largely the same. So a lot of it is, honestly, kind of to your point, Norm, is making sure that you are consulting with an HVAC professional, simply also just to make sure that your HVAC system is working appropriately. And depending on the environment that you all are in terms of the temperature, thinking about ways to continue to have outdoor air in. There are some ways to do that that we've talked a little bit about, like using box fans, for example, in windows. If it's too cold outside, just blowing the air out. But I think some of that is just looking at making sure that you, again, have your system set up optimally and looking at things like portable HEPA filters to help with enhancing air cleaning. I know someone did ask about the ultraviolet germicidal irradiation, and so that is something that's in the guidance as well, although, again, we would recommend if you are going to use that to make sure that you're talking to and that knows how to install that and is really reputable in terms of setting that up for your facility. So a lot of it is just kind of, I think, reaching out to folks that kind of are experts in this area where possible, as well as making sure exhaust fans, both in the restroom and the kitchen, are functional and trying to operate them, for example, before people come into the room or when people are leaving. Keeping those just operating to kind of clear out the air. So I'll put that link in again, just because I know it was a while ago, but for folks that want more detail.
Great, thank you so much. And just a reminder to all the presenters to mute your line if you're not speaking. I think we could hear somebody typing in there. And just a reminder to, hit that mute button. And so I want to send this question over to Marlisa about cash advances. So obviously the CARES Act funding is a lot of money and much more than people are used to. And, money's tight these days. So people are interested in whether they can sort of advance funding to an organization that's, say, providing rental assistance. Can you talk about what sort of at a basic level, what the rules are there, and then where people can find more information about this?
Yes. So the ESG regulations are silent on cash advances, and so we follow, in that case, Part 200, 2 CFR Part 200. So that allows for advances, and recipients need to ensure that when they are providing an advance, that they are issuing a payment with the shortest possible time elapsing between the point where you're transferring funds from IDIS and issuing the payment to the subrecipient. So you don't want to be holding on to it for an extended period of time. You need to know exactly what that money is going to be used for, and that the subrecipient is going to be using it immediately. So it can be really useful when you're getting into a rhythm with your rental assistance payments. That's definitely a way that you could use them effectively. But again, you need to be limiting the advance payments to the amounts that are needed, and then timing it in the right way to make sure that it's in sync with the actual immediate cash requirements that you need to carry out the approved project. So you can't just, in general, advance a lump sum and then not know that it's going to be used by your subrecipient within a specific time frame. So so that's the general guidance, but if you want to look up the reg, it's 2 CFR 200.305. And then if you have any more specific questions, please submit an AAQ.
Great, thank you very much. And I was remiss on our earlier discussion about HVAC systems to ask the follow-up question. And Marlisa, I wonder if you could talk about this, but if somebody did find that they need to make improvements to the air filter system in their shelter, would that be an eligible expense for ESG?
Yes. Yep, it's definitely an eligible expense. If it's more of like a substantial activity, like you're renovating, like you're going into the meat of the building and you're altering like ducting, that sort of thing, that would fall into the realm of renovation. But if you're doing like more minor kind of activities, like replacing filters or more superficial types of changes, then that would be that you could fit that under shelter operations as like a maintenance or maybe even a repair issue or activity, I mean.
Great, thank you so much. So we have a question, Ebony, I think I'll turn this one over to you. If a person was in shelter at the start of the COVID pandemic, so they didn't become homeless directly related to the pandemic, but could you still use ESG-CV funding to help them move into permanent housing under the theory, well, not theory, the actual fact that that being in a housing unit is safer than being in an emergency shelter or being unsheltered? Ebony?
Sorry, double muted. The person who asked this question kind of answered it in the question. I mean, you're literally, even though the person was already in shelter, you're moving them to permanent housing to help also prevent the spread. It's better that person move from a shelter. So this would qualify as prepare for and respond to coronavirus. So.
Great. Thank you very much. Ebony, we have another question here about the mega waiver. So I think the questioner is asking this about mega waiver 2, but I think you could answer this more generally. It's about the about the annual inspections under the COC program. Are projects still required to complete the annual inspections in person at the as a normal HQS inspection?
So in the first mega waiver, the one that was put out on March 31st, that one actually waived the annual reinspection requirement, the 2 CFR 578.75B2 for a year. So the annual reinspection requirement is waived from March 31st, 2021 until March 31st, 2020 until March 31st, 2021. So that waiver is actually still in effect now. The other what they were talking about, the initial inspection, that was some of that was waived, the first mega waiver, but then the actual more information was put out on the last, the third mega waiver. So the annual reinspection one is actually waived right now.
Great, thank you. And what does that mean? It's waived. You just never have to. You just don't have to do it at all, or you just don't have to do it in person.
For the HQ, the reinspection, you don't have to do it at all until after March 31st, 2021.
Great, thank you very much. So we have a few questions here that are sort of repeat questions from previous, that we've addressed on previous calls, but I want to address them real quick because I know not everyone comes on every single one of these calls. So one of the questions is about whether people covered under an eviction moratorium are eligible for homelessness prevention to pay sort of their accumulating rent. So the answer to that question is that there's sort of a test in the homelessness prevention component of the ESG program. There are different parts of the test. There's an income part, and that's below 50% of area median income, or actually it's the very low income standard, which is generally below 50% of area median income. The second part of the test is that they don't have the resources or support networks to be able to move into housing. So that test is generally not met by people who are covered by an eviction moratorium in the sense that they cannot be evicted. So if the eviction moratorium is going to keep them from being evicted, then they wouldn't be eligible for homelessness prevention. I do want to stress, however, that even with the eviction moratorium in place, there are a lot of people being evicted and there are a lot of people becoming homeless. So it is certainly not the case that that you can't do homelessness prevention. There's actually a lot of homelessness prevention that you can do. We do have a document, and we'll try to track it down and put it in the chat window. A document that sort of covers homelessness prevention during an eviction moratorium and talks about some of these issues. The next question, I don't know if anyone's asked this, but I'll answer anyway, is about the point-in-time count. So we are working on some information about the point-in-time count. I actually hope to have something to be able to share next Friday about that. So I don't have any more to share than I have in past calls, but basically we are looking for some sort of different ways to do the unsheltered point-in-time count for 2021. We're exploring a lot of different alternatives and options, and so we will have some information about that coming up pretty quick here, but my hope is to be able to talk about it on next Friday's office hours. So if you have some, well, I won't promise anything, just, hopefully we'll be able to get it done. Lastly, I want to talk quickly about the COC competition or COC funding process. Also no updates there, unfortunately. We are working on trying to figure out a solution for how we can do the COC funding process that does not require the full sort of NOFA and competitive and local competition and all the questions, that full process. So we will hopefully have more information about that at some point, but I don't have any more information about that at this point. Sorry about that. So I want to go to our next question, and Ebony, I think I'll turn this over to you. Somebody was asking about the expenditure deadlines in the ESG program. So, and the question they were asking was, do the expenditure deadlines only apply to the first allocation, or do they apply to both allocations?
The expenditure program, the expenditure deadlines in the notice, that would apply, I believe that applied just to the second Oh, no, they're part of both allocations, I think. I don't know if Marlisa knows, probably can answer better.
That's right. It's September 30th, 2022 for both allocations.
So that means both if you did your first allocation before, like maybe in July, it gives you a couple extra months. But if you have not done your second allocation yet, like you should probably get it done quickly so you have time to expend all that funding, right?
Right.
Great, thank you. So we have a question. Marlisa, I think you may be best positioned to answer this about if you use annual ESG funds for COVID to prevent, prepare for, and respond to COVID, do you have to include the amount of funds used for that purpose and the clients served on the quarterly ESG CV reports?
No, you don't. And William, if you have anything to add to my response, please do. But we will expect that you will report the financial information on the annual ESG funds used to prevent, prepare for, and respond to coronavirus in your annual CAPR, but we will not be requiring you to report separately on client served. So person served, we won't be requiring you to parse out the ones who were served with annual ESG used for coronavirus response versus annual ESG that's not specified for coronavirus response. So you'll report normally as you typically would for annual CAPR reporting for person served, but we will ask you to report separately for financial reporting.
Great, thank you very much. So Marlisa, another question is about procurement standards. So the notice waives procurement, actually the CARES Act, I believe, waives procurement standards for states. Does that also sort of flow down to the subrecipients, or do the subrecipients still have to sort of follow the normal procurement rules?
Subrecipients are required to still follow the federal procurement requirements in Part 200. The alternative requirements for procurement only apply, the flexibilities only apply to recipients. So it is possible if your subs are experiencing an undue burden that you could just contact us and we could see if it's possible to explore any sort of flexibilities on a case-by-case basis, but just provided by the CARES Act and the notice, it's the flexibility only applies to recipients.
Great, thank you. So Ebony, we have a great question here about the waiver on the definition of homelessness that allows people to be considered homeless when they've had an institutional stay of up to 120 days. So the questioner is asking a few different parts, so I'll ask them one at a time. But will utilizing this waiver require that the COC change their coordinated entry policies and procedures?
Well, I would recommend, at least for this waiver and for the time that this waiver allows, for them to change their policy procedures and to allow, because we
Ebony, I think you may have cut out there a little bit.
Recommend that they do change their policies and procedures, at least for the time that this waiver is inactive or is active.
Okay, and that can be as simple, to be clear, as just like put a note in your policies and procedures that say where it says 90 days, we're going to do 120 days. I encourage people not to do more work than is needed, just to be as clear as possible. And so given this, does HUD recommend that COCs adopt this waiver system-wide for all of their COC and ESG projects, or do you think it makes more sense for them to just adopt it on a case-by-case basis?
I mean, that would just depend on the community. I mean, I would to make it easier and consistent to adopt, I would recommend adopting on a system level, but that may not be the case. Like, some communities may not have that kind of issue as far as folks becoming homeless after staying in an institution. To be consistent, I would recommend it, but it does depend on your community. I mean, that's kind of up to the community to see, the COC to see if they want to do that.
Yeah, that's good advice. And then lastly, they were asking about, does that also apply, the change from 90 to 120 days, does that also apply to the 90-day limit that's in the chronic homelessness definition?
So the way the waiver is written, it does not apply for the chronically homeless definition, just the regular homeless definition. So yeah, understand that there's a little bit of, there's a little bit of difference there between a homeless and a chronic homelessness. But right now, it does not.
Great, thank you. So we have another question, and Marlisa, I'm going to sort of turn this over to you because I know you've been working on this one, but it's about using ESG funds for acquisition and the question of what happens after COVID is over and you want to use the building for something else, say for to be a transitional housing or a permanent housing project. I know we're working on some guidance. Can you talk about what just generally what the rules are around this?
Yes. So there's the real property requirements in Part 200 are what we need to follow for temporary emergency shelter because, even though the minimum period of use requirements are waived under the ESG regs, the Part 200 real property requirements still apply. And those requirements basically mandate that you need to follow the real property purchased, acquired, or rehabilitated needs to be used for the originally authorized purpose as long as it's needed for that purpose, which means in our case that recipients and subrecipients have to use temporary emergency shelters for COVID response only for that use up until the period that they're authorized under the notice, which is January 31st, 2022. And at that point, to dispose of, to use the term in Part 200, to dispose of that property, Part 200 gives you two options, and those two options are to retain the title and then compensate HUD. So you would have to repay HUD according to a calculation that's explained in Part 200. And then the other option would be to sell the property and repay HUD based on the calculation that's established in Part 200. Those are the two options at this point. So both involve repaying HUD, and those are really what our limitations are at this point, although, as Norm said, we are looking to explore more options to see if we can provide additional flexibility. And in both of those cases, we would need to work with you if you do use ESG CV funds for acquisition or rehab to provide you with specific disposition instructions. So that's one of the initial steps. We would have to provide you with disposition instructions, so we arrive at a common understanding of what the calculation is and what would be what HUD would expect you to repay in either the case that you retain the title or you sell the property, and then it would also go through the steps of when you're basically like unencumbered and you can, at which point you're able to use the property for whatever you'd like, according to the disposition instructions. So that in general terms is the options on the table.
Great, thank you. I'll take a quick question really quick. Somebody asked about YHDP and any updates on that. I don't have any updates, but I think we're actually very close to publishing that. So please stay tuned. We will obviously send a listserv when that is ready to publish, but I would expect a week or two until we publish that. And then we had another question, Marlisa, I wanted to send your way, and this is about, so there are some questions about so the notice has, the ESGCV notice has some limitations, and the main one I think people are concerned about is the 12 months of rental assistance and the January deadline on temporary emergency shelter. And I think people are asking what triggers sort of when those limitations apply. So if I think everyone knows this by now, but if you had your substantial amendment approved by HUD before September 1st, then those limitations do not apply. But then what if that's the case, but then somebody goes back and amends that amendment they change what they're using their first allocation for? Can you talk about how all that works and what triggers that limitation in that context?
Yes. So if you have a substantial amendment or an annual action plan that was completed, meaning the field office reviewed it prior to September 1st, 2020, then those funds, if it's, let's say it's round one funds, those funds are not subject to the notice limitations. If you were to go back after September 1st, 2020 and make a change, there's only one situation where it would trigger the limitations, and that's when you add a new activity. So if you, let's say you, in your substantial amendment, your round one substantial amendment, you had funded shelter, homelessness prevention, and street outreach. And then after 9/1, you decided to go back and then switch some of your funding around and create a rapid rehousing activity. If you create that rapid rehousing activity for your round one funds after September 1st, 2020, then that rapid rehousing activity is subject to the limitations. The homelessness prevention, the street outreach, and the emergency shelter activities are not. It's only that new activity that you included in your plan on or after September 1st, 2020. So that's one example that sort of encapsulates what triggers an amendment. If you make a change to if you make an amendment that's related to your annual ESG funds or CDBG or home fund, like any of those types of things, that would not trigger the limitations. If you make a change to your round two pot of money, you're submitting like a second amendment for your round two, that would not impact your round one. So we would consider those two separate submissions. Your round one amendment is considered like your application, in air quotes, for round one funding, and then your substantial amendment for round two would be your application for your second round. So those are considered separately. So those are, I think, are the two major situations that we've been asked about. But if you're coming across a different scenario, please ask in the chat or submit an AAQ.
Great. We have one more question I want to get to, which is, I'm going to ask William to answer this. So this is about reporting and specifically about like the retroactive stuff. So if, you know, ESG could pay for activities retroactively, obviously. So if you paid for an activity in, say, June, or you incurred an activity in, say, June, but you did not draw down for it, and you know, yet, and you have a report that's due at the end of October, but you don't include it in the in that report, is there going to be a penalty, or will they be able to sort of fix it in a future report, or draw it down and report it in a future report? Can you talk about how that's going to work?
Sure. There's a couple scenarios here, actually. So there are some grantees that still are actually not under contract, right? You don't have your grant agreement signed. If you're in that case, you actually don't have anything to report. You have no grant agreement. If you have a grant agreement signed and you don't know the expenses because you're doing that retroactive work, which many COC or many ESG recipients are doing, but you haven't quote unquote approved any costs at this point, then you'll simply indicate that you have the grant agreement signed and entered no costs. At the point that you know you've approved something, but you don't have all the information there, right? It's not uncommon to know that you approved costs incurred in June, but you may not have all that information until November. First of all, we'd certainly encourage you to get everything in within this initial reporting period, all costs incurred for the period up to 9/30. However, we know not everyone will be able to do that. We'll give you an opportunity to amend the APR. There are some technical challenges to that, so it's not something I would recommend if you can avoid it. But we understand that there are many of you who may need to do that, and we will provide a path to do that, and you'll work essentially with the AAQ, and we'll have our contractor working through Sage also work with you to ensure that we get that all ironed out.
Great, thank you so much, William. I want to thank everyone who joined the call today. I want to thank all of our presenters, especially Sandy and Barbara and John. Thank you so much for sharing that information on telehealth and working with high-risk individuals. So I also want to thank our technical assistance providers who just sort of keep this whole thing running smoothly every single time. And very much want to thank my co-presenters from the SNAPS office and for getting all this stuff organized and answering increasingly challenging questions. And most of all, want to thank everybody for joining the call today. As always, I just want to say again how thankful we are for the great work you're doing. These are not the easiest times to do this stuff, and it's been disruptive for all of us. So thank you so much, and please reach out to us if you have any questions, any technical assistance needs, or anything. And I hope you have a great rest of the day and a great weekend. And that concludes the webinar.